Hi, good morning. Can everyone hear me? Thank you. Welcome to today's session on Let's Get Digital, Changing the Game in Health Information Management. My name is Margaret English. I come from the Doctors of BC. I'm involved in the Joint Collaborative Committees, and I feel very fortunate that I've been asked to moderate today's session. So I just want to start with our traditional acknowledgement that the land on which we gather is the unceded territory of Coast Salish people, including the territories of Musqueam, Squamish, and Tsleil-Waututh. So I'm from Vancouver and live on the Squamish lands. So I'd like to start our morning off with inviting May Tuason to the podium here to talk to us about the COVID-19 vaccine management digital health solution through a quality lens. Welcome, May. Thank you.
Thank you very much. Good morning, everyone. Oh, here's the slide. As Margaret mentioned, I'm May Tuason. I'm a registered nurse with the Digital Health Strategy Office. It's a relatively new office that's jointly partnered and managed between the Ministry of Health and PHSA. And today, I'm fortunate enough to share with you BC's story of its COVID-19 vaccine program and digital solutions. On behalf of all the teams who played a role, and there are a few faces here, including Jeb from VCH, who participated in some of the work I'm going to be speaking to today. So show of hands, who lives in BC? Show of hands again, did you or your loved ones ever go online and register for your vaccine? Great, okay. So you actually participated in some of the programs that I'll be speaking to today. And as Margaret also mentioned, I would also like to acknowledge that we are gathered on the traditional and ancestral lands of the Musqueam, Squamish, and Tsleil-Waututh nations in this place known as Vancouver, where I live, work, and play, and so does my family. And so we're very grateful for the First Nations for having stewarded this land and continue to steward this land. And I give thanks as an uninvited guest. I have nothing to disclose, so I won't be mentioning any specifics about the different partners that we have worked together with so closely. But if you have any questions, please let me know. And then I also wanted to say, in addition to reflecting on our success coming together in the face of the pandemic, I would also like to acknowledge our healthcare workers for all you've done and gone through to continue providing care and keeping our healthcare system accessible throughout these unprecedented times. So thank you. And I also want to remember those we have lost to COVID and acknowledge the personal sacrifices and challenges we faced during these unprecedented times. BC does have incredible support resources. So, I know many of us are taking this year to try to recover, but then also try to keep up with all of the continued work. So please reach out when you can, speak to your leaders and your peers. I know EFAP and some of the resources that you find online have certainly helped me and my colleagues and family. So every time Dr. Bonnie Henry and Minister Adrian Dix took the podium to guide the people in BC through the pandemic, a dedicated team of leaders, clinicians, service agents, writers, communicators, designers, technologists, and volunteers stood behind them to help the people follow public health orders and stay safe. The story of BC's success in the face of a pandemic is a testament about the power of teamwork and people-centered goals through a global emergency. Together, through tight coordination between national, provincial, regional leadership, operations, communications, and digital solutions, we address key challenges from reaching at-risk remote and Indigenous communities, managing inventory and supply distribution around the province, to standing up and managing capacity of vaccine clinics, large and small, urban to remote, across our regional health authorities, and later with our pharmacy partners across almost 1,100 local pharmacies. Expertise across sectors and at joint tables all reported up. Literally, we all reported up to Dr. Henry, Minister Dix, and Dr. Penny Ballum. It was almost like no table, there was no table that had a veto, essentially. anytime we raised any risks or issues, we knew that we weren't by ourselves to manage those risks and issues. We had our colleagues, our leaders, and all the way up to the Deputy Minister, in fact, and Minister Dix, to help us go through any legislative concerns, privacy or security concerns. So it was really wonderful to see how folks, gave a little and then took back a little. And then in the end, through the compromise and some of the challenges that were resolved with legislative and regulatory issues, we were able to get our work done because the stakes were high. Oops, did I lose my place? There we go. Provincial health orders stalled whole industries and asked people to stay away from work, from travel, and their loved ones. I'm sure you all remember and still are living this today in some respects. People needed information in the simplest terms to help flatten the curve in a way that met their needs. We used every medium possible for maximum reach. Press conference, live streaming, social media posts that reached over 300 million views, plain language summaries of provincial health orders online with over 220 million views, news media releases and events, contact centers with live agents on the other line in case, of course, about 20% of folks that did interact with the system and to get their vaccine didn't go through any of our digital solutions at all. So there was reach out to those that didn't have access to telephone and so on, community reach outs for folks to be able to express interest to get the vaccine and so on. And then telephone and video town halls connecting people to their local leadership. And as you can see here, the quality inclusive information was complex. Information was made available in 12 languages. American Sign Language translation happened during live streams. And all throughout, our goal was to keep the message positive and consistent and encouraging people to use good judgment to do the right thing in extraordinary times. And that's my niece in the middle there. The news of the COVID vaccine arrival came in the absence of any system or service capable of vaccinating over 4.5 million people twice over with a booster, and that needed to happen within a 12-month period. We knew we needed a system for much larger volumes to engage and vaccinate up to 65,000 people a week at the height of the campaign, and the system had to be simple and flexible to support our most vulnerable people. A blend of public servants and private sector partners worked day and night to build the Get Vaccinated system. As you can see here on the screen, that might look more than familiar to you. And people could then go online and register. So this is just some information. You're welcome to take a look at some of the materials online for more information. The provincial call center was stood up along with the online system, and at the height of the campaign, agents handled 50,000 to 70,000 calls a week. Health authority and pharmacy providers used the IMMSBC digital solution to manage notifications, reminders, appointment scheduling, inventory, vaccine documentation, and real-time data reporting and analytics by our tremendous provincial analytics and regional decision support teams. It took us only 9 weeks to go from product goals on a virtual board. All of this work was done virtually. I think we had only started to meet our team members this year, just 2 months ago. And we were able to stand up a minimum viable product in a live environment in that short amount of time. We followed agile methodology, Scrum, within 2 to 3 week sprints, for those that are technically inclined, to continually release features and enhancements based on user experience, operational data, and the ever-evolving vaccine strategy. 60 releases and hot fixes later, we continue to keep up with our ever-evolving COVID vaccine campaign, with vaccine for the 6 months to 4 years old just around the corner. Change management and support and training were needed for over 24,000 users across the province to transform the way they offered vaccine. And as the vaccine program continued, I don't know where to point. I'm sorry. As the vaccine program continued, we needed to make ongoing changes and to, for example, reschedule clinics due to the severe weather. If you remember summer of 2021, heat domes, wildfires, and floods. And it was really amazing to see some of the cross-sectoral collaboration happening for problem solving to reach those communities that were cut off. When vaccination rates began to plateau, leadership made a bold decision to order that only vaccinated people, those with 2 doses of that vaccine, could enter non-essential services like restaurants and gyms. That's very political, as you all remember. In the space of 10 days, we stood up that vaccine card, and that was, provided a visual proof of vaccination to be easily checked at those public venues. And it could also be downloaded and printed. We received over 300,000 calls requesting vaccine cards to be printed and then mailed to folks that didn't have access to digital online tools. In terms of privacy by design, we ensured that we were using systems that could manage sensitive information, and we did have our security and privacy officers, not just at the time of creating the PIA and the STRA, so the privacy impact assessment and the security risk assessment. They were there with us in all of our team meetings, making sure that they could provide timely responses to the way that we wanted to support our populations. To ensure quality throughout the campaign, research, especially focusing on equity, was done, physically going out and talking to people. So for example, parents, we went to swimming pools, we went to community centers, and we talked to folks about how the service was working for them at each step of the process. This included not only parents, but seniors, First Nations communities, and people living on the margins of society about their needs and experiences. And again, a big hand to the regional health authorities who went to those neighborhoods like our downtown east side and actually had mobile vaccine clinics to go and offer those who were not without home. As a result of our joint efforts, I'm sorry, this is increasing time. As a result of our joint efforts and commitment, BC is emerging from the pandemic with the following outcomes. One of the best protected populations in the world, with a 90% plus vaccination rate. As of April 8, almost all provincial restrictions were lifted, in large part due to this high rate. As of February of this year, the Get Vaccinated and IMMSBC platforms had supported, amazingly, registration of over 4.5 million people, over 50 million, that says 35 because this was done back in October, over 50 million SMS text notifications, 18 million email notifications, 9.7 million booked appointments. All this while keeping people at the center of our work and achieving high satisfaction rates. And this is what I'm most proud about, but I know we can always do better. 97% satisfied or very satisfied with getting their shot. 87% provider satisfaction from almost 900 respondents, and a justifiable cost per capita, I personally have to say, with the hundreds of thousands of lives that were saved from serious illness, hospitalization, and death. Our partnership across the sector, across disciplines, continues to learn at our joint tables, and British Columbians, based on the feedback from online, in-person, and phone-in service options, so we can gather our success factors and tailor our supports as we transition to a pandemic phase. And so with that, with everyone's help, every individual who participated in the campaign, we helped each other to flatten the curve. We helped people get vaccinated, and we helped the economy going, and hopefully are now returning to a new sense of normalcy. And as we saw in our joint efforts against COVID-19, we proved we can positively impact our health and well-being when we work together and put people first. Thank you so much, and looking forward to your questions.
Any questions for me? We have microphones going as we go. Please raise your hand. Thank you.
Thank you for your presentation. My name is Christine. I'm with Island Health. So wonderful. I think as well, IMMSBC also has the easy link to the federal vaccine card. Is that correct?
Yes, that's right.
That was a really nice addition. It made it easy when everyone thinks they have to download one more vaccine card. So from the provider perspective, for those that were working in the mass immunization clinics, it was very valuable for them to be able to actually understand what their credentials were, because there was certain, whether you were a nurse practitioner or whether you were a physician, you had different modules that you had to take. So that was all incorporated in there. So that was also seamless. Our experience from the medical affairs side, when we had, as all of the health authorities did, to implement the mandatory vaccination PHO order around all healthcare workers. We found information gaps on the back end, which were, I hope, going to be fixed, and that was just the different systems that were tracking who was immunized and who was not. So we had the one system where we had what's called the white database with the panorama, and those healthcare workers who had been immunized very, very early on at the front line. So that was probably what we learned from information sharing, and I think the province is trying to rectify that sort of disconnect between the different sources, because if you weren't through IMMSBC at the front end, then you weren't showing up in either of those data sets. So it was good learnings, and I think also we hope that we can clean up the data in between. So when, the date of birth gets switched around, that those things are done sort of on the back end, more as a QA versus, now we've got to figure out who's who and whether they've been vaccinated or not. So well done. I think it's a great system, and we appreciate it from a health authority side.
Thank you so much. And just to quickly address the mention of the data that is different between different systems, I guess that is a symptom of disparate systems having been used throughout and early on. And Jeb, I think we're still recovering from this for Vancouver Coastal. I remember December 14, 2021 was the very first shot for the COVID vaccine that was administered in Vancouver Coastal and in Fraser Health. And I remember from December 11 to December 14, we received an internal mandate that everyone in the province should go on to a temporary form. Everybody went on one temporary form, 3 days to stand that up across the province. And then we switched over. But even so, with the IMMSBC system that managed, I guess, the majority of the vaccination requirements, there were still systems locally that were being utilized. And to your point, absolutely to this day, data remediation is absolutely one of the critical components to ensure accuracy of who received the vaccine at the end of the day. We also opened up a line to allow folks to call in and actually help to remediate their own data. So they were identifying their own issues with their record and calling in and requiring remediation as well and correcting. So as we're thinking about how do we leverage some of these systems, going forward, it's really important to look at end to end and where can we try to minimize the disparate systems across, but then also help to maximize the way that we can support our reporting teams, our analytics teams for better data so we can move towards a higher quality learning system for sure. So thank you so much for your question.
Hi, I'm with Vancouver Coastal Health and working in the Analytics Decision Support Department. And so I think we connected a few times during the pandemic. And I first want to congratulate you on such a fast development of a system that has, such a beautiful front end interface, and from the public perspective, I think was really successful. I hearing other health authorities talk of similar experiences around some of the data struggles that we had and challenges on reporting and back-end systems. And I know those things kind of often come last when you're in a rush. But with the benefit of hindsight, I'm just wondering what might you do differently kind of next time, and what were your learnings around like how you might design something differently, and what can you share with us for going forward with this type of system design?
I really hope that we don't need to do it as fast, and I hope that we are more comprehensive in terms of bringing all of the work streams together right up front. I can remember our reporting working group, there was a lot of confusion at the beginning saying, we're already implementing systems here. We were already ready to use our regional systems. So it actually did come as a surprise to all work streams that we were all moving to one singular system for sure. Lessons learned now, I'm really hoping that we can leverage some of the systems that are starting to emerge in COVID, and then now start to consolidate or increase the accessibility of some of these tools that are required for accurate reporting. So thank you. Thank you.
We're going to move on to our next speaker. May, if you're around, can people come and talk to you and ask you questions at the end of the session?
Absolutely.
Okay,
Thank
sorry
you.
to cut off questions. Thank you very much, May. What you've done was amazing. Next, we have Jeb Dykema, who's going to come to speak to us about making great governance. And it sounds like, Jeb, you've done a lot of work with May, and we're in there full on. So thank you.
Yeah. Thank you. Morning, everyone. This stays where it is. Morning, everyone. My name is Dykema, and I'm going to talk today on making great governance. Who here has been involved in developing a governance structure or process before? Excellent. My condolences. It's not an easy process. We're going to talk today about this. It's a hot button topic these days, and there's a lot I can mention. But my goal today is just to highlight a few common elements, a few things you can put in place to make great governance. We apply it to clinical information systems today, but these elements you can apply anywhere, these principles. So that's my name. I am the Director for Clinical Informatics for Vancouver Coastal Health in the community space. We have an acute kind of clinical informatics, and we have community. So everything outside of the acute sites, mental health, home health, public health, et cetera, that's where I've worked closely with May and others. And I do not have any bias. I should have just said that instead of all these other bullets, but no bias. You be the judge, actually, we'll see. Governance simply means the structure and process by which decisions are made. This may seem very simple, but often it's the simple things that elude us when we're putting together a governance structure. We focus on process over structure, and we're going to talk today about mainly the structure of governance. Just like some have life coaches to help make better decisions about their own futures, we need a strong decision-making process to assist with our organizational health. This must include our clinical information systems. Otherwise, we will just bumble along, wake up one day, and think, how did we get here? In 2018, I had a few of these how did we get here questions when our team was formed. I had a long list of change requests for our information systems that were on hold. And if you've worked in IT, you know on hold means it's never going to get done, right? Or it may not get done. It's that black hole. We had no clear process of how to get things done. There's the holy grail in the middle, like I got my change request in, but you're not quite sure how to get it done. How's it get approved? How's it get prioritized? And that leads to a frustrated leadership and frustrated users. For a vast system, some of our systems have thousands of users, and they're frustrated when the change is not keeping up with the pace of clinical change or the practice change that they're implementing on the site. Too early. Can I go? There we go. And they were right to be frustrated. Year by year, there's an increasing demand for quality healthcare data and information to make better decisions. Decisions related to funding, service outcomes, or even just to inform a patient's treatment plan. And we have a user base that's more savvy every year with technology, and they want to see that savviness they have in their information systems. They want to see technology integrated. They want it to help guide their practice. So we get, of course, increasing demands. And it's only going to increase. Currently, 30% of the world's data volume is healthcare data. By 2025, the compound annual growth rate of data for healthcare is anticipated to reach 36%. That's 6% faster than manufacturing, 10% faster than financial services, and 11% faster than media and entertainment. So it's just going to grow at a faster rate than any other sector. Clinical practice is always changing. We have practice changes every day, acute and community, to improve the quality of care and patient outcomes. More and more, the systems are not just required to keep up, but they're required to enable the change for better information sharing and better tools to apply those clinical practice changes. Decisions must be made at an organizational level around how to shepherd these required changes, how to approve, how to prioritize. There's more, if you work in IT or you work in informatics, you have long lists. There's always more on the list than you have resources to do the work. You have to approve, you have to prioritize, you have to line up. Governance requires bringing order. Order does not come naturally. Disorder comes naturally. It doesn't just happen. If you do not invest energy into establishing good governance, you will have the loudest voices get what they want, or you'll have the IT department driving change, separated from the clinical priorities. In order to build great governance, the organization must make it a priority. To demonstrate, this is a typical Friday night text conversation with my wife as I stop at the grocery store on the way home. Don't buy junk? That's her. Who says? I do. Why not? Because we're eating healthy. Who says? Just don't buy junk. This is almost every Friday. I won't tell you what actually happens. Without even knowing it, she's providing two of the most important governance principles. There are many more, but if we get these in place, the rest will follow. Within VCH, oh yeah, there we go. There we go. So here's our two principles. Who says, and how will they agree? So who says? Within Vancouver Coastal Health, we have dozens of clinical information systems. We have about 24 of them, and that's a problem, and we're fixing that elsewhere. Ideas for change to the systems are constant. New modules, new forms, new tools, new fields, new assessments, always. And we have a savvy user base that has a lot of light bulbs. And they have a lot of change. They have a lot of demand for change. They're looking at it and going, this could be improved. I'll send in a change request. If managed correctly, these requests will improve the system and make it more usable and useful to the users. And here's them writing their change requests and those changes going through. And we have had this historically. We've had changes sent on to IT, those changes are enabled, and then we have system changes. We have one EMR in BC that I know of that has a list. It's called service. And so what service are you providing as a clinician? There's 700 items in the list because everything that clinicians wanted was just enabled. Now, 700 items. Emily, at Decision Support, if you have a list of 700 with no definitions, these poor people have to put that together into some kind of data. And that's when you don't have governance, that's what happens. You just have a system that becomes a bit of a monster because we make changes, but we rarely take anything away, right? We're just always building on, never refining. We have to refine and we have to build in good governance. And that's that first question. Who says? Who says these changes are going to happen? Who says this is the priority? So we determined to find the right people. Who says? And we developed a checklist to guide us. It must be clinical. It has to be close to the action. Too often we've had decisions made by people who are not close to the action or close enough to what's actually happening on the front lines. And there's lots of memes out there. There's lots of neat pictures of how the developer imagined it, how the clinician imagined it, and they're not the same thing, right? You need to, oh, there's my timer, shoot. This is the most difficult piece, but the efforts will bear fruit if we take governance out of the hands of the IT department or teams like mine, and we put them into the hands of the clinicians or the operations leadership. So here's what we built at Vancouver Coastal. Here's our governance structure for community systems. We have our regional programs for all of our different program areas, services, and then we have decision makers at every level. It's important, though, that they understand they are the decision makers. Establishing this was not easy. This took from 2018 to now. These folks now know that they are decision makers, and that's a key. When you say who says, the people need to know that they are decision makers. People who know they are in charge, they have responsibility then, if they know that they're in charge of a decision. If you just kind of bumble along, people make decisions and they go, well, I didn't know. Well, no, you need them to know. You need them to know that they're in charge of that. It doesn't just happen. It takes effort and time. The second key is people who others know are in charge. So you've got to know yourself that you're in charge, and others need to know that this is where decisions are made. And this is, if you don't have this, you have a black hole of IT, where you send in change requests and you don't even know where those are going, right? They're going onto an on-hold list that you'll never see. You need to know where these decisions are being made and who's in charge, so you can advocate. In the story about Friday night junk food, my wife and I came to an understanding. I don't check my texts on the way home. With health authorities, it's not this easy. It's not easy to get a group of people to make decisions if they all have vastly different priorities, or different experiences, or different information, or just different personalities. You need more than just who says. You need more than just a group of people. You need to have a shared vision. You have to have a vision. How will they agree? Has to be a vision. Even in the Bible, there's an interesting proverb. It says, without vision, the people are disordered. And you can see that in your own life, and you can see that in any governance structure. You need to have a vision. If you don't have one, you'll have the questions, what are we building? Why is that a priority? Why are we doing this? Why are we approving or not approving these items? You'll have that from the leaders, you'll have that from the clinicians, you'll have that from everyone. A common vision provides the banks to the river for decision making. And for VCH community, we have a vision statement. You'll get the slides after, I won't read it out for you. But we have a vision statement, it just provides those banks. These decisions now line up with a vision that we have. We're all moving in this direction. We'll disagree on some things, but we're all heading this way. Eventually, we'll get there. Because we have a shared vision, we now have some principles to make decisions based on the vision. Again, you're just building in these structures to help your governance folks who now have a responsibility and an authority to do it well. And you need to have principles in place. Next steps. Some of the next steps we're going to do to make it even better. We have good governance. I wouldn't say we have great governance. We're going to get there, though. And we're going to get there little by getting feedback from our governance committees. Increasing transparency. You can't increase it enough. If you want to build trust, you have to build transparency. Clinicians, managers, directors need to know where decisions are being made so they can advocate. And so they can know if something's a no, then they know why. Right? And no on hold. Get rid of on hold. That's my presentation. Any questions?
What is your approach to leadership turnover? Because there's been a lot of people moving around these days.
Yeah, that's a really good question. We have committees made up of more than a few people. These committees are usually 10 to 15 people. So when you have leadership turnover, I am regularly attending these committees and regularly giving a slide deck similar to this one. So they know at least every 6 months, I'll go and just give a review to the group. And I think they'll see it in the month-to-month meetings when I'm bringing decisions or my team's bringing decisions to be made. But we do need to constantly massage this in because you're right, it can be easily forgotten and then frustration happens. Hey there.
Hey, Jeb. Thanks for the presentation. Curious as to, from a transparency perspective as well as messaging, how are you getting that message out as to these decisions, how they're moving along, when they're being made?
Yeah.
Obviously a challenge in any organization.
Huge challenge. We just moved to a new work item management tool in the last couple of years. And so that has really helped. We now manage our work items within this tool. My next step is to make the status of every work item public. So anyone can log onto a website. We want the output from that tool to go onto a website where they can filter and look at all the change requests that are being done, all the work items that are being done within the system. And then they can filter down to their particular program, what they care about. And if something's a no on there, it has to have a reason. So we're not there yet. Right now, we're just bringing spreadsheets and slide decks to committees and saying, here's what came in the door this last month. Here's what we've done. Do you want to change the order of these things? It's a bit of a kind of a face-to-face process, but I want them to be able to go pull it eventually. And that's I think, the gold star of transparency, if we can get that. Hey there.
Thanks for the presentation, Jeb. So it's great to see you have a framework for the decisions maker. What is, how does the factor of funding affect those decision makers and their shared vision? Can you provide any insight on that?
How does the funding affect it?
Yes.
Yeah, that's a really good question. We are funded for a certain number of resources every year to do regular ongoing maintenance within our IT systems. So that's between my team and our IT department. We fit this governance. This governance fits into those decisions. So we just do things ongoingly. We have so many resources. We do so much work. When it comes to additional funding, we have to slot those in, and sometimes we'll bring in additional resources. And so if we have a capital item that comes through, even if someone's able to go and get funding, we still have to have it approved by governance. There's still that checkbox. And that's something that is a regular conversation when a user comes or a team comes with money and says, here's money, we want to make this decision, thinking that's going to fast track governance. We have to slow down and say, should we do this, regardless if you have the funding in place? Because it's going to affect everybody, and it's going to affect the data. Poor Emily and her team, they need to know about these things ahead of time.
Thanks for this presentation. I'm curious if you have any tips on deciding who gets to decide in terms of perhaps a group that you want to be part of the decision maker that doesn't want, or vice versa, the opposite.
Yeah, that's a really good question. I think you have to come up with a checklist of who you want. Like who, not thinking of people, but thinking of positions or checklist of what their characteristics should be. How close are they to the action, to the clinical practice? How close are they? Do you have decision support involved? Do you have professional practice involved? You need some key players within your governance structure, but you have to have operations. So I would come up with a checklist and then look around your organization and say, where do these people exist? One of the bullets I had on there that I didn't mention is really important. Leverage existing committees wherever you can. Because as soon as you create a new committee, then you have a new invite in people's calendars, you have competing priorities. But if you can leverage an existing committee that already has a good membership and people attending regularly, and take 10 minutes, that's all we do, 10, 15 minutes every meeting for some of our regional committees to bring our updates, get them to approve, prioritize, and just kind of massage that in every month, then that's really kind of borne fruit for our team.
Great presentation, Jeb. Thanks
Thank
so
you.
much. What I really appreciate about that is that discernment between roles and responsibilities, or who's accountable and who's responsible. But my question is do you vertically implement, like, who is consulted, informed, like who is not the decision maker as well, but who needs to be consulted or needs to be just informed of a decision? Have you drilled down that deep in terms of governance?
It's a good question. We do once we get a work item approved, and then we'll develop a RACI or a project charter for that work item. But I think even before that, one of the pieces where we can struggle is making sure that our governance bodies have enough information to make a decision. There's always that pre-analysis work. When you have a request come in, now you bring that and everybody goes, that's a great idea. And then when we do it, and then afterwards you go, oh shoot, we didn't look at the cons, right? Or we didn't even think about that. So we have to do enough of an impact analysis to make sure if I'm now responsible to make a decision, I know what I'm making. I know the possible impacts of it. And so there's that piece as well, and that's just kind of some pre-analysis work we do with IT, with decision support, with others, before we greenlight something. Great. Thank you.
Jeb, thank you very much. Again, a lot of great work, really good questions. And I think about the consultation, the last question, I think of that IAP2 spectrum of engagement. And when I do some of my governance work, that's always in my back pocket. Okay, who are the decision makers? And then I go to who needs to be consulted. So thank you for that last question. So our next group is coming to us. There's 3 young ladies that are here to speak to us, prototyping an end-to-end platform for genomic care to meet the needs of both patients and providers. So please join me in welcoming Frannie MacKenzie, Julia Handra, Shani, Norte, Tangkhpanya, if I've said your name correctly. Thank you.
Hi, everyone. My name is Julia. This is Shani and Frannie. We feel very fortunate to be here today in person, joining you on the lands of the Coast Salish peoples. And we're very excited to share some of the work that we've been doing in prototyping and implementing an electronic platform for genomic medicine. All right. Is it a long press? Oh, sorry. Okay, perfect. So we have no disclosures or conflicts of interest. Oh. Gotcha. All right, thank you. All right, so genomic technologies allow us to understand an individual's genetic makeup and how that influences their health. These technologies are becoming more powerful and more accessible and are therefore revolutionizing options for care and diagnostics in BC. As such, the BC Provincial Medical Genetics Program is receiving an increasing number of referrals each year. However, genomic medicine relies on the integration of multiple data streams for which the infrastructure is currently missing in BC systems. Therefore, clinicians are trying to provide this complex and needed service, but they are facing barriers due to increasing and rapidly expanding deficits in information management. So our goal was to improve the quality of and the capacity for genomics-informed care by developing a platform that can host a secure patient interface, guide care practices using standardized forms and tools, automate administrative and redundant tasks, and can also consolidate data from across a patient's journey through the whole clinic so that we have an information management system that can provide guidance in both patient and clinic management. To develop this platform, we first had to consult the clinic and learn more about their processes and needs. So we consulted both clinician and staff to improve workflows, as well as to gain an understanding of the tools that they required for their practice. Functions to support a future state were customized and built into QI/QA REDCap. The platform was first launched in April 2021, and we have since been in the process of working with the clinic to improve these functions based on feedback, as well as to develop new functions.
So what is REDCap? So REDCap is a secure web-based platform that is used to build and manage online databases as well as surveys. So REDCap is originally a research platform, but there's also a quality improvement, quality assurance REDCap, or QI/QA, that collects data for the purpose of either clinical decision-making, program evaluation, or for the Provincial Medical Genetics Program, we actually use quality improvement, quality assurance REDCap for operational support to streamline day-to-day tasks. So why was REDCap chosen as the platform for the PMGP? Well, first of all, it offers a lot of customization that allows us to create instruments that were similar to the instruments that were used prior to the implementation of REDCap. In addition, it allows for a lot of automation of communications to both patients and the clinic staff. It also has a ton of data exporting tools by way of raw Excel data or customized reports or templates, as well as PDF printouts of the instruments and the data collected. And lastly, as Julia mentioned, the field of medical genetics is constantly growing and constantly evolving. And with REDCap, we can easily make changes that allow the platform to adapt and grow with the program. So this is a list of the current instruments that we have built into REDCap. And here are some examples of when you actually click into the instruments. You can see there are a lot of different functionalities, and they all look a little bit different because they're collecting data for different reasons.
Currently, REDCap houses over 10,000 patient records, including all of the information that was shown in the instruments in the previous slide. And it is used by over 60 clinicians and staff in the clinic, including the physician geneticists, the genetic counselors, and all of the administrative staff. As such, this platform allows the clinic to streamline the very many processes that take place when a patient is first referred to medical genetics to when they receive results for their genetic testing.
All right, so to showcase some of the utility of the platform we've developed, we thought we would do some before and after case studies of key functions that are accomplished, starting with patient triage. So when a referral is received to the program, a clinical team will assess the patient's needs to determine what kind of care is most appropriate. This requires a lot of consistency, not only between clinicians, but also across time. In the past, triage would be completed on paper. The information would then be redundantly back entered into a spreadsheet by a secretary, and this entire process was prone to human error as well as interpretation and inconsistency. Now there is an electronic triage form which guides clinicians through consistent decision-making. So triage data for each patient will populate a printout for the chart as shown in the slide above, and will also populate a program-wide tracker so that we can easily track all referrals and understand where we are at as a program to manage the clinic.
In terms of communication, as with many clinics, appointment booking is done typically over the phone, and then a follow-up email confirmation is sent with the details of the upcoming appointment. Prior to REDCap implementation, each booking clerk would send a manual email confirmation, as well as personally keep track of every incomplete form. This contributed to yet another task for support staff and also left room for patients to potentially be missed. Now, after consent, REDCap sends a standardized appointment confirmation email and automatically alerts the booking clerks when the forms are yet to be completed.
So there are currently 3 patient-facing components that are built into our REDCap system: the pre-appointment questionnaire, the request for information consent form, and the medical photography consent form. Prior to REDCap, all 3 of these were separate forms that had to be manually emailed by clinic staff to the patients, who either had to mail them back or scan them and email them back to the form or to the clinic. Now, with REDCap, all 3 processes have been streamlined into a single patient communication that is triggered by a check of a box by clinical staff that includes a link to the questionnaire and both the consent forms, as well as a secure photo upload section, which makes the process a lot easier for the clinic. And we did query all patients who were sent the pre-appointment package after implementing the consent or the e-consent process, and we are seeing really good completion rates of all 3 components. For example, we're seeing about an 89% fully or partially completed rate of the pre-appointment questionnaire.
Phenotyping, or the process of determining the set of observable characteristics of a given individual, is done by the geneticist as part of the appointment and requires some form of documentation. And so usually this varies from physician to physician. Previously, phenotypic information was written in chart notes and then buried in the paragraphs of a clinical letter. And now with the implementation of this phenotype instrument, a patient's phenotype is captured in a much more discrete and standardized way, which is then also used better downstream by the lab and in performing genomic analyses. Once a patient has been consented and a genetic test has been ordered for them, information regarding this test, including the patient identifiers, the test type, funding approval, and expiry, are all recorded. One reason for this is to follow up with the patient if they have not yet gone for their blood draw, but also to track tests across the whole program. Before REDCap, test tracking was done on Excel spreadsheets. I'm sure we have very many of those for each physician, producing over 15 different spreadsheets to input data. This required manual checking of each spreadsheet for the funding expiry and redundant data entry across multiple platforms.
So we're continuously looking to iteratively improve the platform with feedback from both the program and patients. In addition, we're always looking for different facets of the program that we can implement into REDCap to improve clinical flow. So we do keep an open line of communication with the clinical staff. They tell us what's working, what's not working, and what part of their job could be implemented into REDCap to make it a more streamlined process. In addition, we have a designated space on the patient-facing components that allows them to provide anonymous feedback that is used in conjunction to make changes to the platform. It's an ongoing cyclical process. I even say the list of instruments that we had listed is probably not the same as what it actually looks like now. And while there are a lot of functions that have improved the workflow for the program, it doesn't come without limitations. So first, it's not an electronic health record. While the information can easily be downloaded in customizable reports and templates, the information still needs to be stored elsewhere. Secondly, not all the patient records are identical. Because it is an iterative process, some patients are added before certain components are implemented into the platform, which results in inconsistencies within the data set. And lastly, there are a lot of functions, but we are limited to the functions that REDCap does have to offer. So there are certain things that we would like to have, but we just can't. And we do work with the BC Children's Hospital Research REDCap team to use everything that they do offer.
All right, so the current platform is very much a clinical prototype. It models the functions that would be needed in a more sustainable and EHR integrated solution. Software development along with EHR integration is necessary to make these processes more streamlined, but also to scale up use to more clinical services. Overall, technological innovation and integration is absolutely necessary to empowering and enabling the patients and providers that are eager to participate in genomic medicine. And before we take any questions, we just wanted to thank the patients and family members, the clinicians and staff, and the many groups that we've consulted, such as REDCap, the Office of Virtual Health, Privacy, Security, who have provided guidance, insight, and feedback throughout this entire process. Thank you so much.
Thank you so much for that very informative presentation, very fascinating. I was just wondering what the difference is between regular REDCap versus QI/QA REDCap. And also, where is this information stored? Is it BC Children's, they have the program, or is it elsewhere, an outside organization?
Yeah, so REDCap is institution-based, so ours is hosted by BC Children's. And the difference between the research REDCap and the QI/QA REDCap is the kind of the functionalities that it offers. Research REDCap, essentially, it's meant for research projects, whereas QI/QA is more of the clinical side of REDCap. It's newer, not many programs use it, but there's a lot more with like the data team. You have to get a lot more approvals. I don't know if you want to touch upon it.
There's just generally many more layers to security of the data. So for example, in this QI/QA arm of REDCap, all data is stored within the PHSA network and not through the same as the research arm would be. And like Frannie mentioned, we usually have to consult many groups before implementing certain functions or changes in the platform, just to make sure that patient safety and security is prioritized.
Thanks for the presentation. In terms of the patient-facing component, did you come across any feedback or issue related to the digital health readiness of the patient and families filling out the forms and uploading, et cetera?
Sorry, just to clarify, are you referring to feedback from families in their ease of access?
Correct, and using the boxes and the forms that are designed electronically for them.
Yeah, for sure. So the patient feedback has actually been very helpful. What we have is a few boxes at each, or a few fields at the end of each patient-facing components where families can provide their input or what they've struggled with in completing the form, and that's really informed our direction in REDCap as well. For example, when we first started e-consenting, we required that patients downloaded a PDF and then re-uploaded, and we received a lot of feedback that was causing a lot of frustrations and issues and was acting as a barrier for consenting. So we worked with many groups at the PHSA to actually implement a new e-consenting process within REDCap where we can actually capture the patient's wet signature instead of asking them to go through all these different hoops to provide very basic consents.
Just in follow-up to that question, so what about the non-respondents? Because there was like a gap of people who weren't using the tool. So what was the feedback you received from those people?
I'm not sure about what exactly the non-respondents, I'm not sure if they responded or not in terms of feedback, but with every digital system, for example, with the Provincial Medical Genetics Program, we deal a lot with patients and families with intellectual disability, and so for some groups of our patients, it's harder to get a hold of them, harder to get them to fill out, to address the previous question, there are always barriers to getting patients to fill out digital questionnaires and send in photos. So I think we always have the backup of doing what was previously done and just calling or having the family come in if they're not able to send in pictures or take pictures because they don't have a phone. So we always offer them the option of coming in instead and doing it during the appointment.
Great, thank you. So before you run off, can you please take a moment to fill out your evaluation, preferably online is our best choice because it automatically goes in. If not, please use the forms that you've got provided. And I want to thank all three of the groups for presenting. I think these are great examples of how healthcare really is becoming digital. So next you're off to lunch. We're upstairs for a sit-down lunch. So we're a few minutes early. So thank you.